Hello, good morning, everyone. My name is Navitya Ramesh, and this is Dr. Garcia. We will be talking about the year in review for asthma and COPD. So just before we start our session, just a couple housekeeping announcements. So this session can be evaluated through the mobile app, so please evaluate the session. And also the session is being live streamed, so I would request you to refrain from speaking in the vicinity of the mics. And also CME claiming for the session is available, and it opens tomorrow at noon. So I'm Navitya Ramesh again. I'll be talking about the year in review for asthma. I do not have any disclosures. So my goal today is to highlight the findings of few clinical studies in asthma within the past year. I know there are a lot of studies that came out, but I just picked a few of them which were interesting. So the first study we'll talk about is the Sigma-1 study, which is Symbicort given in mild asthma. So this study was published in New England Journal in May of 2018, looking at inhaled combined budesonide formoterol as needed in mild asthma. I have to begin the study by saying that it was funded by AstraZeneca. The study was, the goal was to assess the safety and the long-term efficacy of using as needed ICS/LABA in patients with mild asthma. As you can see, it's a double-blind, multi-center study, randomized study for 52 weeks. The population chosen was mild asthmatics, age 12 and over. They were divided into 3 groups. The first group had twice daily placebo and as needed terbutaline, or short-acting beta agonist group, as needed. They did not have any inhaled corticosteroids in the group. The second group had twice daily placebo with budesonide formoterol as needed. So this is the as needed ICS/LABA group. The third group had twice daily budesonide plus terbutaline as needed. So this is the scheduled inhaled corticosteroid group. So the goal of the study was to compare to see if as needed ICS/LABA was superior to as needed short-acting beta agonists. The primary objective was to investigate the superiority. So if you can look on this, I'm sorry. So the gray line is budesonide maintenance group, where you see that's much better than the other 2 groups. So if you're on inhaled corticosteroid maintenance twice daily dosing, your asthma was better controlled. However, the comparison, the goal of the study was to look at the other 2 groups, which is the budesonide formoterol as needed, which is the red one, and the short-acting beta agonist as needed, which is the blue one. And the ICS/LABA as needed was better than, was slightly better than the short-acting beta agonist as needed group. So they also looked at the time to first exacerbation. The budesonide formoterol as needed, it prolonged the time to first severe exacerbation when compared to the as needed short-acting beta agonist. So this was divided into both severe exacerbation and moderate to severe exacerbation. And once again, the scheduled ICS did much better than the other 2 groups. So the results and conclusion of this study were the annual rate of severe asthma exacerbations was 0.20 with the short-acting beta agonist alone, as needed. It was 0.07 with the budesonide formoterol as needed, and it was 0.09 with budesonide maintenance therapy, which was interesting. So it's superior, the budesonide formoterol is superior to as needed short-acting beta agonist, but inferior to the budesonide maintenance therapy. And one other interesting thing with this study was the total dose of the inhaled corticosteroids was much higher. It was 340 micrograms if you were in the maintenance group. So your total steroid dosing was higher in the maintenance group as compared to the ICS/LABA as needed group. The steroid dose was only 57 mics. And another interesting point of the study was the rate of adherence to the BID dosing of the inhaled corticosteroid was about almost 80%. Do you think we see 80% in real life medication adherence? Not really. So these patients got reminders to use their BID ICS dosing, and so they used them. So now this study is called Sigma-2. This was designed parallel to Sigma-1. They asked this specific question: as needed budesonide formoterol or as needed ICS-LABA versus maintenance ICS in mild asthma. So they took the short-acting beta agonist away. So it's clearly proven that short-acting beta agonist is inferior compared to the other regimens. So now they're comparing the other two regimens here. So this is a multi-center study. It was done in 354 sites in about 25 countries. And they basically compared Symbicort Turbohaler with Pulmicort Turbohaler. So once again, the duration of the study is the same. It's double-blind, multi-center study, 52 weeks. The same patient population, mild asthmatics, age over 12 years. They used the budesonide formoterol as needed with BID placebo compared to twice-daily budesonide alone and as needed terbutaline. And they looked at the same annual rate of asthma exacerbation and the asthma quality score. Again, the study was funded by AstraZeneca. So the results of this study, as needed ICS-LABA was non-inferior to the scheduled BID ICS dosing to reduce asthma exacerbations. The time to first exacerbation was similar in both groups. However, this is interesting. The as-needed group, as-needed ICS-LABA group, was inferior in controlling the asthma symptoms based on the ACQ-5. And the median daily dosing of inhaled corticosteroid in the as-needed group was 66 mics, as opposed to the scheduled inhaled corticosteroid. The total dosing of inhaled steroid was higher. So this study, the strength of this study is nobody got reminders to use their ICS scheduled. So this is more of a real-life study where the patient adherence to medications is not great. And so the thought was if they are short of breath and they need to use a medication that will affect their disease process, ICS-LABA would be better with decreased total steroid dosing. However, this was just a 6-month study, so the duration is short, so we don't know what implications this will have on the long-term airway remodeling in asthmatics. So asthma is considered, the reason for airway remodeling was considered to be chronic inflammation. But this study brings out a proposal that the remodeling could be due to worsening inflammation at the time of exacerbation rather than the chronic inflammation. So the goal is how do you prevent those exacerbations and hence prevent remodeling. So there's an ongoing study, Australian-New Zealand clinical trial registry, which is looking at something similar, and it's a longer duration. So hopefully we'll have our answers from that. The next study I'm going to talk about is quadrupling the inhaled glucocorticoid dose to abort asthma exacerbations. So previous studies looked at doubling the inhaled corticosteroid dose in asthma, and they found that if you're going to have an asthma exacerbation or you are in yellow zone or zone 2, when you doubled your inhaled corticosteroid dose, it was not effective in preventing a full-blown asthma exacerbation. So the question here was, okay, let's not double it, let's quadruple the dose. So at the same time, another study came out in the pediatric population where they looked at increasing the inhaled corticosteroid dose by 5 times. So this study was done in UK, and I'll talk to you a little bit about the zones of asthma that they used. So zone 1, they considered it well-controlled asthma. You don't need to do anything with your medications. Zone 2 is the group we're targeting, where the patients are having deteriorating asthma control, and this is the group that's targeted. So if you find out that the asthma control is starting to deteriorate, would quadrupling the ICS dose at this particular time prevent a full-blown asthma exacerbation? Zone 3 and 4 are actual exacerbations, and 3, you might need oral steroids, and 4 is hospitalization. So this is a double-blind, this is an unblinded study, randomized trial for 12 months duration. The adult study looked at the adults and adolescents with asthma who were receiving inhaled glucocorticoids with or without add-on therapy. And all these patients had at least 1 exacerbation in the past year. So it's interesting to note that at least 50% of the population had an asthma exacerbation needing steroids within the past year. That's the population they looked at. The intervention group consists of self-management plan, where if the population, if they noted an increase in they noted deteriorating asthma control, they increased the dose of inhaled corticosteroids by a factor of 4. They quadrupled the dose. When compared to no such increase in quadrupling the dose. So the outcome was the time to first severe asthma exacerbation, and they defined the asthma exacerbation by either they're using systemic steroids or they have an unscheduled healthcare consultation. So in the total patient population, about 60%, they reached the zone 2, and they qualified to be assessed. So based on this, this is the participants with exacerbation, and this is the day since randomization. And you can clearly see that the ones who were in the quadrupling group had less exacerbation compared to the ones in the non-quadrupling group. So the results of this study was 45% of patients in the quadrupling group. That is, if you think your asthma is deteriorating, increase your ICS dosing by 4 times. Versus 52% in the non-quadrupling group had an asthma exacerbation. So it was much less in the quadrupling group. But the interesting point with this study is the adverse effects of the inhaled corticosteroids was higher in the quadrupling group. So the most common adverse effects that were noted in the study were hospitalization for asthma. There was not too much difference, surprisingly, in the pneumonia incidence. Both groups had similar incidence of pneumonia, the quadrupling and the non-quadrupling. The other adverse effect that was looked at was oral candidiasis was higher in the quadrupling group. So hence the study, we cannot make very strong recommendations because of the risk-benefit ratio. Yes, it improves, it decreases the exacerbation, and yes, it increases the adverse effects as well. So it does not have a great risk-benefit ratio. And also in the pediatric population, just to mention, the quintupling group, or the group of children 5 to 11 who increased their ICS by 5 times, they actually had decreased growth rate in these children, or about like 0.23 centimeters per year. So this is not very strongly recommended strategy. Now coming to the main study, which is a combined analysis of asthma safety trials of long-acting beta agonists. As you may recall, the SMART trial in 2003, the basic conclusion of that was long-acting beta agonists increased the mortality rate in patients with asthma, and hence FDA placed a boxed warning on LABA medications for management of asthma. So FDA also mandated the 4 large manufacturers of ICS, LABA, to do large-scale randomized controlled trials to see what exactly happens when patients are, or asthmatic patients are on an ICS and LABA. The caveat of the SMART trial was a large proportion of those patients who were in the SMART trial in 2003 were not on inhaled corticosteroids to begin with at baseline, which we now know is the backbone of asthma management. So FDA mandated all these, the 4 drug companies to have intervention group, which is ICS with LABA combination, compared to ICS alone. That way, every single patient who was in the study was on an inhaled corticosteroid. So prospective randomized controlled trials, there were 4 trials by the 4 drug companies. One of them was dropped in 2015 because their LABA was no longer manufactured in the US. It's a 6-month study just to prove the non-inferiority of the ICS LABA in patients with asthma. There was 1 pediatric study as well, and I will talk only about the adult studies. So the primary outcome was the composite of asthma-related intubation and death, and the secondary outcome was asthma-related events or asthma exacerbations. So I will concentrate mostly on the composite endpoints because asthma-related intubation and death were extremely low. So there were 36,000 patients in this population. Let me show it to you. And here, so these are the 4 drug companies: AstraZeneca, Glasgow, Merck, Novartis. Novartis is the one that dropped off because they no longer manufacture their LABA. And you can see the serious asthma-related events were not significantly better with ICS and LABA, and they divided these patients, the population, into various subgroups based on age, sex, race, BMI, and that too, they did not show, the ICS-LABA combination did not show any significant decrease in asthma-related events. However, when you look at asthma exacerbations, you see that ICS-LABA is better in preventing asthma exacerbation, and that was proven in all the studies. And even on the subgroup analysis, when you divided them into various subgroups, asthma exacerbations were reduced when using ICS and LABA combination as opposed to ICS alone. So now, this is a good thing, right? So asthma exacerbations are decreased, hospitalization decreased. However, the majority of this exacerbation group was basically those who needed systemic steroids for more than 3 days. So exacerbation comprised of 3 things. One was either they increased the steroid dose or for 3 days, they have inpatient hospitalization or ED visits. And the benefit that we see here is mostly due to increase in the steroid dosing. And they did not really affect the hospitalization. So conclusion is the combination of ICS-LABA is non-inferior to ICS alone. ICS and LABA resulted in fewer exacerbation, but did not reduce hospitalizations. It's a large study, there's a global reach, and there was less heterogeneity because it was FDA mandated, and it was a very well-done study. The limitation is the biased recruitment and the reluctance on the patient's end, because you're telling the patients, LABAs have shown to increase mortality, do you want to participate in the study? So that's a bias there, and we cannot generalize the results to other countries. This is primarily in the United States. And we just see a class effect. We're not saying this ICS-LABA is better than that ICS-LABA. It's the class of the combination of the inhaled corticosteroids and LABA that are better. So it's basically a class effect. And importantly, those with severe asthma, including those with a history of intubation, were excluded from this analysis. So the takeaway point would be, yes, we can use ICS-LABA in patients with asthma. And hence, in December 2017, FDA removed this boxed warning on the combination products containing ICS-LABA in the management of asthma. Now moving on to more severe asthma. There were 2 interesting studies that came out in NEJM this year, Liberty Asthma Quest and Liberty Asthma Venture, both of which looked at dupilumab. So what is dupilumab? It's anti-interleukin-4 alpha monoclonal receptor antibody. This blocks both interleukin-4 and interleukin-13 signaling. So they wanted to see if this dupilumab was safe and efficacious in patients with uncontrolled asthma. So this was, again, a randomized controlled trial for 52 weeks, adults and adolescents, young adults with asthma, anyone over age 12 with uncontrolled asthma. The design of the study is interesting. They had a 2:2 to 1:1 ratio to receive add-on subcutaneous dupilumab at a dose of 200 mics or 200 milligrams or 300 milligrams every 2 weeks, or matched volume placebo. And the control received only placebo at every 2 weeks subcutaneously. The primary endpoint was to see if there was annualized rate of severe asthma exacerbation was decreased when you use dupilumab, and also did it affect the lung function as well. So the absolute change in the FEV1 from baseline to week 12 was assessed. And the other interesting point of the study is they subgrouped these patients and they looked at secondary endpoints where the exacerbation rates and FEV1 was looked in this particular group of patients who had an eosinophil count of 300 or more per cubic millimeter. So you see the risk of severe exacerbations, whether you use dupilumab 200 milligrams or you use dupilumab 300 milligrams every 2 weeks, it was decreased. And the effect was mostly seen in patients. It was stronger in those who had an eosinophil count of more than 300. And as compared to the other biologic studies, this one looked at FeNO, or exhaled nitric oxide. And as you can see, the ones who had a higher FeNO, greater than 50 parts per billion, they did have an improvement with the dupilumab as well. And again, change in FEV1, they looked at change in FEV1 right here at week 12, and there was a significant change in FEV1 in the patients who received dupilumab as opposed to those who got placebo. The results were similar in whether you use dupilumab 200 milligrams or dupilumab 300 milligrams. So the conclusion is the annualized rate of severe asthma exacerbation was 0.46 in the dupilumab group as opposed to 0.87 in the placebo group. So yes, they reduced the severe asthma exacerbation. There was a 47, almost 48% reduction in the exacerbation rate with dupilumab. At week 12, when they assessed the FEV1, the pre-bronchodilator FEV1 had increased by 0.32 liters, and that was significant as well. The interesting part of this study is the blood eosinophilia. The blood eosinophilia occurred more in patients who received dupilumab. So the reason for this is dupilumab acts on IL-4 and IL-13, and it works on eosinophils entering the organs, the target organs, or it does not actually prevent the eosinophil production in the bone marrow, which is controlled by IL-5. So this does not block IL-5, so the bone marrow continues to produce the eosinophils. This just blocks the effects on the tissues. And the subgroup analysis in those who had a blood EOS of greater than 300, also the annualized rate of severe asthma exacerbation was much lower in the dupilumab group as compared to the placebo group. So dupilumab reduced the rate of severe asthma exacerbations. The patients had better lung function. When you looked at the FEV1, they had better asthma control. And also it was more beneficial in those who had higher baseline eosinophilia. The second study, again with dupilumab, they asked a different questions. Okay, so dupilumab is good in severe asthma, but is it good enough to reduce the oral corticosteroid dosing in these patients? So the Liberty Asthma Venture is the efficacy and safety of dupilumab in glucocorticoid-dependent severe asthma. This was a randomized controlled trial of only 24 weeks duration, and it had about 200 patients. And all these patients were on oral steroids for their management of asthma. And dupilumab was added on to their regimen at a dose of 300 milligrams every 2 weeks, and placebo was given every 2 weeks. The primary endpoint was to look at the percentage reduction in the glucocorticoid dose at week 24, and the secondary endpoints to see if at least 50% reduction in the glucocorticoid dose was achieved, and what proportion of the patients were able to be taken down to 5 milligrams of glucocorticoids a day. It's important to note that these patients, the exacerbation rate was pretty high in these patients, and that's why they had to be on controlled oral steroids daily. And as you can see, the first one here, the oral steroid dose reduction, is much higher with dupilumab, which is the blue one, as compared to placebo. And FEV1 change from baseline, the blue is dupilumab, that was also better when compared to placebo. This shows similar effect with patients who had eosinophils greater than 300. They showed a greater effect as well. So it's interesting to note that 70% in the dupilumab group had the steroid dose decreased, as opposed to 40% in the placebo group. Why do people decrease their steroids in the placebo group? I'm not entirely sure about that. And there was 80% versus 50% of the patients in whom the steroid dose was decreased to 50%. So yes, dupilumab is useful in decreasing the regular maintenance steroids in patients with severe asthma. Just moving on to a slightly different topic, I'm going to briefly talk to you about this study, which is very, very interesting, in my opinion. This is the COPD gene study, a 5-year follow-up. Basically, it was looking at adult smokers with COPD. So these patients, they were initially recruited, and they came back for the 5-year follow-up, and that's when they started looking at what's going on with asthma in these patients. The inclusion criteria was the patients who actually participated in the COPD gene study, the initial study. They were 45 to 80 years old, and they had at least 10 pack-year smoking history. Those who had any other lung disease were excluded. If you were not a smoker, they were excluded from the study. If you had lung transplant or lung volume reduction, they were all excluded. So this is primarily a smoking population who had COPD. So how does asthma play a role here? Kind of talking about more asthma-COPD overlap. So these patients, when they came for the 5-year follow-up, they completed the respiratory epidemiology questionnaire, MMRC dyspnea scale, St. George Respiratory Questionnaire. So they did PFTs, and they also had expiratory and inspiratory chest CT in most patients. The outcome measures were These outcome measures were, did they develop COPD? They did not have COPD to begin with. They were just smokers. Did they develop COPD in the 5-year period? They have chronic bronchitis or respiratory exacerbations needing antibiotics. So when they analyzed the study, they found that 3 of these respiratory illnesses were very important. The first one is childhood pneumonia. That's pneumonia diagnosed less than 16 years of age. When they followed these patients, they had a lower lung function, increased risk of developing COPD, and increased airways disease on chest CT. The second disease looked at was childhood asthma. In this cohort, how many of them were diagnosed or said they have asthma less than age 16 years? And these patients were followed up, and they found that asthma, if they had any component of asthma, they had a smaller subsegmental airways. However, this was not associated with lung function decline or CT changes. And then they characterized this third group, which is asthma COPD overlap. So that's the patients in this population who were thought to have COPD, but they did get a physician diagnosis of asthma when they were less than 40 years old. And as you can see, they were younger than COPD population. The FEV1 reduction was similar to those of COPD without asthma, and they did not progress to CT emphysema as much as COPD patients, which I thought was interesting in this study. The last one I'm going to mention very briefly because even cardiologists are paying attention to asthma these days. This study looks at association of asthma and asthma control with atrial fibrillation. So HUNT-1 was a survey study done in Norway, and the HUNT-2 and HUNT-3 are reiterations of this study that was done in Norway. About 50,000 participants were followed for 15 years. So when they looked at these patients who did not have atrial fibrillation to begin with, when they followed them 15 years later, and they found that the patients who had a physician-diagnosed asthma in the 15-year period had an estimated 38% higher risk of developing atrial fibrillation. So I think we'll hear more about this topic in the future. And those are all the studies that I picked for this year. I know there are more interesting studies, but I like these better. Now I'm going to hand this over to Dr. Garcia, who's going to talk to us about the studies in COPD.
Hi, good morning. So we're gonna be using this at the very end for just a single question. So I'm Dr. Javier Barrera Garcia, and I'm a faculty with the University of Texas in Houston. And I'm gonna be talking about the COPD today. So these are my disclosures, so nothing significant. And these are some of the abbreviations that you're probably already familiar with. But when we talk about a LABA, we're gonna be talking about a long-acting beta agonist. LAMA, long-acting muscarinic antagonist, ICS, an inhaled corticosteroid. And when we talk about triple inhaled therapy, we're going to be talking about the combination of these 3. So this is the outline. So we're going to be talking about 5 different papers. And these are the ones that I thought most likely are going to alter your management of these patients, in the next year. So the first one deals with is one of the bases for the new diagnostic recommendation for COPD in the GOLD 2018 report. And this one deals with the stability of the COPD diagnosis. The next 2 are the long-awaited comparisons of a triple inhaled therapy versus a dual long-acting bronchodilators. And these ones are going to help us clarify the role of ICS in patients with COPD. And the last 2, they are related to the 2018 FDA approval of an endobronchial valve. This pertains to the phenotypic patient with emphysema. And for this one, I'm going to ask for your help on the clarifying kind of the final recommendation. So talking about the first topic, this is a little background information about the diagnosis of COPD. This is per GOLD 2018. And the new change is that they are recommended to repeat the spirometry if the FEV1 to FVC ratio is between 0.6 and 0.8. And this is partially based on this paper that I'm going to show you. So we're going to try to analyze the paper in the context of this new recommendation. So this is the paper, and this is the research question that they were trying to answer. Can the spirometric diagnosis of COPD change over time in patients with mild to moderate airflow obstruction? So for that, they analyzed data from a couple of cohort studies, the Lung Health Study and the Canadian cohort of obstructive lung disease. The first study included more than 5,000 patients, and the second one about 1,500. And they included a mixture of patients with and without COPD. The patients with COPD, primarily they have just mild to moderate airflow obstruction. And this is what they did. They follow the patients, and on a yearly basis, they perform a spirometry. And then this is kind of the average time of the study, almost 5 years for the first one and about 4 years for the second one. And this is one of the primary diagnostic points that they assess, what they call diagnostic instability. And patients would qualify for that if they will fulfill this criteria here. So on the first one, they started with a spirometric diagnosis of COPD, then they reverted to normal, and then they were COPD at the end of the study. Or the opposite happened, started with normal, then COPD, and then normal again. So this is the diagnostic instability results. So you have the percentage of patients there according to the lower limit of normal or using the fixed ratio, and you have the two studies there as well. So as you can see, the percentage of patients with diagnostic instability goes from anywhere from 6% up to 20%. And in general, there was less risk of this happening the further the FEV1 FVC ratio was moving away from the diagnostic threshold. And this is just to give you an idea. So if you're at 0.7, the instability risk is around 40%, and that decreases as you're moving away from that. The other major outcome that they assessed, or the major thing that they assessed, was for diagnostic reversals. So these are patients that started with a diagnosis of COPD, and then by the end of the study, they reverted back to normal. And this is what they found, kind of a similar situation, anywhere from around 8% to up to almost 30%. And again, there was less risk of a reversal the further you were moving away from the diagnostic threshold. And interestingly, if your FEV1 to FVC ratio was below 0.65, there was a 95% probability of just remaining with the diagnosis of COPD by the end of the study. And smoking cessation increased the chance of reversing the diagnosis of COPD. This is by spirometry, of course. So back to the original question, can the spirometric diagnosis of COPD change over time in patients with mild to moderate airflow obstruction? So, their main conclusion is that is the case. And this is the percentage of patients with either diagnostic instability or diagnostic reversal. So this is leading us to the GOLD Report 2018 recommendation. So based on this paper, another one that is similar, they recommend that if you have a FEV1 to FVC ratio between 0.6 and 0.8 to repeat the spirometry. So in the next few slides, I'm gonna try to convince you that maybe that shouldn't be done. But you can come up with your own, with your own thing. So, first we're gonna try to answer the question, can the FEV1 to FVC ratio give us certainty regarding the diagnosis of COPD? So, and here you have a scale that is representing the FEV1 to FVC ratio. And kind of in the middle, you have the diagnostic threshold. And in general, we classify as patients that are having a higher number above the diagnostic threshold as not having COPD, and patients below that threshold as having COPD. But as you might remember, this is not perfect, and you might remember this New England Journal paper from a couple of years ago showing that some patients that are classified as not having COPD, this is based on a normal ratio, They are still behaving like patients with COPD, having significant symptoms, significant exacerbations as well. So to some extent, this diagnostic threshold kind of creates the illusion of having certainty because you're assessing a number, but this is not entirely perfect. So let's think about the FEV1 ratio a little bit more. So what defines normal and abnormal? For the FEV1 to FVC ratio, in general, uncommon numbers are the ones that are classified as abnormal. And this is from large data of patients. You know, the numbers that are uncommon for certain populations are gonna be classified as abnormal. And in the end, the experts came up with the best numbers that are gonna maximize sensitivity and specificity, either 0.7 or the lower limit of normal. And even the experts cannot, generally agree, which one to use. And in general, the higher the number, you have increased confidence that you're ruling out COPD. And the lower the number, you increase your confidence that this is COPD. And of course, extreme numbers, you can be pretty confident, so there is certainty that you don't have COPD. And extreme numbers in the opposite direction, you're probably very confident that you have COPD. But in the middle, there is a higher uncertainty as to whether or not you're actually dealing with COPD or not. And near the diagnostic threshold, in my opinion, the values look more like a probability rather than a yes or no answer. That's kind of the difficult thing, in interpreting these studies. So should we repeat the spirometry if the FEV1 to FVC ratio is between 0.6 and 0.8? So we're gonna go back to this model. So let's think about the hypothetical case in which there's a small change in the FEV1 to FVC ratio when we're repeating the spirometry. The change is small, but it's crossing the diagnostic threshold. So let's say that you're moving from 0.71 to 0.69, for example, you're moving in the opposite direction. So even though the diagnostic threshold is crossed, you can probably ask, has the probability of benefit from COPD treatment significantly changed? What is the real difference, for the actual patient, in which the threshold is just being crossed, but just by a little? And of course, if there is a big change, definitely the probability of having COPD or not is definitely gonna change. But the question here, what defines a significant change? And that's something that we don't know at this point. I would imagine if there is a significant change, it's something that you might be able to capture on clinical grounds. A patient that is, obviously was having acute bronchitis, or a patient that has asthma, for example. But the most important, point is that there is no evidence that repeating the spirometry might improve outcomes. And you can wonder as well if it can potentially worsen outcomes for some of our patients. So what should you do, if the FEV1 to FVC ratio is close to the diagnostic threshold? Well, I think we have to accept that in these patients, we might not have a definitive answer. And of course, the diagnosis of COPD is not only based on the spirometry, it's based on clinical factors as well. We cannot rely more on the number because we think it's more exact, but you have to, in this situation, you probably have to rely a little bit more on the, smoking history, your symptoms, and some more things. And I would recommend to continue to follow current evidence-based treatments. So for this section that has to do with the COPD diagnosis, I think this paper is important. And it helps us understand that the spirometric diagnosis of COPD can change over time. This is applicable for patients with mild to moderate airflow obstruction. And this is just in my opinion. If the FEV1 to FVC ratio is close to the diagnostic threshold, my recommendation is just to continue to treat the patient, to treat most of these patients as usual. And this is because the current therapies that we have, they were evaluated with a single spirometry. And then, of course, heavier reliance on clinical factors in this patient population to assess the probability of COPD. So now let's talk about the second topic. So it has to, in this one, we're going to try to clarify the role of ICS in COPD. And this is a little background information, kind of in my mind, the classification of the inhalers in the world of COPD. And on this scale is based on how well the different inhalers are going to be for a symptom control and/or prevention of COPD exacerbations. So kind of in my mind, at the very top you have the LAMAs, probably a second best at LAVAs. Not that great, the ICS. The ICS not only is not that great, but it is also associated with increased risk of pneumonia. So in the next two studies that I'm going to show you, the authors were asking the question, if I combine my best two players, and that is the LAVA and LAVA, can I get rid completely of the ICS? ICS is not very effective. ICS is associated with increased risk of pneumonia, and that is exactly what they did. So they asked the question, is triple inhaler therapy better than a dual long-acting bronchodilator in reducing COPD exacerbations? So here you have the first one, the IMPACT study, and the TRibute study. And the IMPACT, so it compared triple inhaled therapy versus either an ICS and a LAVA or a LAVA and a LAMA. In regards to the annual rate of moderate or severe exacerbations. So moderate exacerbations are those that are going to require antibiotics or steroids, and severe ones are the one in which the patient is going to be admitted to the hospital. And it was nice in that they used the same delivery mechanism, so they use a dry powder inhaler for both groups, and the same active ingredients, just a combination is what varied. And they included over 10,000 patients. TRibute, also similar comparison, triple inhaled therapy versus LAVA-LAMA, the same primary outcome. Here the delivery mechanism was different, MDI versus a DPI, and the active ingredients were similar with the exception of the LAVA. And they included over 1,500 patients, so kind of a smaller study. So we're going to analyze these two together. And they were both performed as randomized multi-center trials, and the patient were followed for about 1 year. So these are their inclusion and the exclusion criteria. So you have the IMPACT at the top and TRibute in the bottom, and I'm going to walk you through these. So you can see these are patients that are significantly symptomatic, and this is based on the COPD assessment test. And they were at high risk of exacerbations in the future, so this is called Group D. Most of these patients were on a long-acting inhaler for the preceding months. One of the critiques in the IMPACT study is that about 40% of the patients were already on triple inhaler therapy before the trial started. However, TRibute is compensating for that because the patients on triple inhaler therapy were actually excluded. And then most of the patients in the two studies were already on an ICS. Importantly, patients with a current diagnosis of asthma were excluded. However, if they had a history of asthma, it's possible that they might have been included in the study. And this is for IMPACT before randomization, patients were allowed to continue their own inhalers for 2 weeks. In TRibute, they were assigned to a LAVA-LAMA combination. And these are the results of the primary outcomes. So you're looking at the annual rate of moderate or severe exacerbations. You have the two studies there, and you have the different groups. So, and I'm going to walk you through this as well. So looking at IMPACT, triple inhaler therapy was in general better. And you can see the relative reduction there in the annual rate of exacerbations. In TRibute, the decrease was not as marked as compared to IMPACT, but there was also a significant reduction. So these results are a little contrary to what was seen in the FLAME study. So in comparing ICS-LAVA with the LAVA-LAMA combination, IMPACT is telling us the ICS-LAVA is better, and FLAME is telling us the LAVA-LAMA is better. So what is the reason for that? And I think it's probably because of different study designs leading to differential benefit. So for example, IMPACT included patients with a history of asthma if the diagnosis was not current. Inflamed, they were more picky, and they excluded any patient with any history of asthma, onset of respiratory symptoms prior to age 40, and elevated blood eosinophil count, some more things. Inflame also, prior to randomizations, patient received tiotropium for about 4 weeks. And here you can think if a patient would benefit from an ICS, maybe even prior to randomization, the patient could have withdrawn from the study. In IMPACT, they were allowed to continue to take their own medications prior to randomization, possibly better capturing the consequence of ICS withdrawal. So this is just looking at subgroup analysis. So you have the rate of moderate or severe exacerbations in IMPACT according to a blood eosinophil count. So low and high. And you can see there is a reduction in both, but it's more prominent if you have a high eosinophil count in the blood. And something similar was seen in the in Tribute as well. So this is just subgroup analysis. So it's just it's just hypothesis generating. So you have to be careful here. And we're looking at side effects. If the patient were on an ICS, there was increased risk of pneumonia. And this is about an increase of 3.5 events per 100 patient years. So if you have an ICS, you're decreasing exacerbations, more, but you also have increased risk of pneumonia. So to compare apples to apples here, you have the rate per 100 patient years of moderate or severe exacerbations. And you can see here, in general, for the, on average, the decrease in exacerbation was more prominent than the increase in pneumonia. So back to the original question, is triple inhaler therapy better than a LABA/LAMA in reducing COPD exacerbations? So based on these two trials, the answer is yes. And the triple inhaler therapy reduced exacerbations by around 15 to 25% versus a LABA/LAMA combination. So the take-home point doesn't change the recommendations from the GOLD guidelines, even before these studies. And the idea is to consider to add an ICS in COPD patients with frequent exacerbations despite use of a LABA/LAMA combination. As I was telling you, this is applicable for patients with COPD group D. What to do with this asthma situation, whether or not the patient were included or not. I think you just have to, to apply this to the same population that they study. And these are patients without an active diagnosis of asthma, but variable history of asthma, variable blood eosinophils, and variable sputum eosinophil, which is something that was not assessed in this trial. I wonder for future studies if you make all of these categories negative, if the ICS is still beneficial for those COPD patients. So in my mind, this is kind of where we started regarding the different inhalers. And in my mind, the ICS has moved into a better category now. And from these studies, I learned that the risk of COPD exacerbations, probably decreases more than the increased risk of pneumonia. This is in the general, in general for these patients. And possibly, if you have increased eosinophils, patient might even benefit more, from the ICS. So now let's talk about endobronchial valves. So these two studies assess the question, can endobronchial valve treatment with the Zephyr valve improve lung function versus the standard of care in patients with heterogeneous emphysema? And you have the Liberate trial here and the Transform trial. Liberate was done as an RCT, almost 200 patients. Transform similar, but almost 100 patients. In Liberate, they followed the patients for about 1 year. It was mainly done in the US, and Transform for 6 months, mainly done in Europe. And they compare endoscopic lung volume reduction with the Zephyr valve versus what they call standard of care. There was no clear definition of a standard of care. That was just free, for the clinicians to continue their usual care. And their primary outcome was a clinically significant improvement in the FEV1, and this was defined by the FDA for the US study. And these are their inclusion criteria. So this is a combined one for the two studies. So they have to have severe reduction in the FEV1, but no less than 15%. They have to have air trapping, 6-minute walk distance, not below 100. And all the patients that were enrolled, they were actually non-smokers. So the category that you see missing here is the FEV1 to FVC ratio. So these are patients with the emphysema, but might or might not qualify as having COPD, based on the FEV1 to FVC ratio. And there was no requirement for minimal symptoms, but just based on their mean numbers on the MMRC and the COPD assessment test, they were significantly symptomatic. Exclusion: patients with the most severe lung disease were excluded, and this is the criteria that they used. If they were at high risk of infections, they were excluded as well, and that is based on sputum production, history of pneumonia, history of COPD exacerbations. So this is not for people that are having frequent exacerbations. And then patients with significant heart disease were also excluded as well. So this is kind of their initial screening criteria. Then patients underwent CT chest. And this is to evaluate for the presence of heterogeneous emphysema. And they calculated what is called the emphysema score, and that is the percentage of each lobe that has emphysema. And this is the emphysema definition, so less than minus 910 Hounsfield units. So their score looked like someone like this, so 40, 15%. Among the different lobes, they identify a potential target lobe, and that have to have an emphysema score of more than 50%. And then the difference in their emphysema score with the ipsilateral lobe had to be at least 10 or 15%, depending on the trial. And the idea here, of course, is that with the valve, you're going to cause atelectasis or the most diseased lobe. The better lobe is going to expand and it's going to work better, and it's going to allow for the diaphragm to work better as well. So the ipsilateral lung has to be better. The ipsilateral lobe has to be better function than the target lobe, of course. After identifying a potential target lobe, the patients underwent bronchoscopy. And the idea of this is to identify the presence of collateral ventilation, any communication between the lobes. If there was collateral ventilation, the patient were already excluded. If there was no collateral ventilation, the patient was randomized to the endobronchial valve group or to a standard of care. Patients on the standard of care, they were discharged. And unfortunately, they were not blinded as to the study intervention. I know this is probably easier said than done, but if they could have blinded this patient, they could have protected against a placebo effect. And they had already done, the bronchoscopy and everything, but patients on the endobronchial valve group, they were admitted to the hospital for at least 5 days in one of the studies, and at least 1 day in the other one. So these are the results of their primary outcomes. So you have the percentage of patients with a significant improvement in the FEV1, and you have liver rate at 12 months and the transform at 3 months. And you can see this is favoring the endobronchial valve group. The number needed to treat is between 2 and 3. And on further secondary outcomes, there was improvement in the quality of life with the endobronchial valve, and also improvement in their walking distance. Among the side effects, pneumothorax was the one that stood out, and about 1/3 of the patients developed a pneumothorax. This happened at a median time of 1 day. And with most of the cases happening in the initial 3 days. Importantly, about 13% of the cases happen after 1 week. This is after, potentially the patient is out of the hospital and there's still potential risk for a pneumothorax. And most of the pneumothorax require an intervention. So this is death. And you have the numbers here for death in both groups according to the study. And as you can see here, the study wasn't powered to answer this question. The number looks, bigger in the endobronchial valve group, but it was not statistically significant. When you look at deaths related to the endobronchial valve, and this is determined by the investigators, you have the numbers there. So 3% in one group, 1.5% in the other one. So this comes at around the 2.6% for EVV-related deaths, or about 1 for every 40 patients treated. So a few uncertainties remain here. One is if the background therapies were similar in both groups. I understand these patients might or might not qualify as COPD, but different inhalers might affect, the FEV1 and some of the outcomes that they assess. And that's something that wasn't described in these papers. The second one is this standard of care equal to maximal medical therapy. If patients qualify for COPD, for example, what if we have them all on triple inhaler therapy, as we learned? Would they have seen similar benefit or not? It's unclear. To what extent can the results be due to a placebo effect? The long-term risks and benefits, remain a question. This study is only, one of the studies evaluated the patient for 6 months, the other one for 1 year. So in the long run, it's unclear. The effect on mortality, there is no question that there are some deaths that are immediately related to the endobronchial valve placement. The long-term mortality effect, is unclear. And more importantly, do the benefits outweigh the risks? So here's where you're gonna help me. So, so how likely are you to offer endobronchial valve treatment to your patients with emphysema on a scale of 1 to 5? So 1 is highly unlikely, and 5 is highly likely. Yeah, so what I see is probably the majority are not sure, but it's kind of, mainly evenly distributed all over the place. So very. Yeah. Yeah. So let's look at the conclusion for this section. Can endobronchial valve treatment with the Zephyr valve improve lung function versus the standard of care in patients with a heterogeneous emphysema? And here the answer is yes, based on this paper. And on average, 2 or 3 patients need to be treated with the endobronchial valve for one to experience a clinically important improvement in the FEV1. So this is my take-home point. So in patients with emphysema, with uncontrolled symptoms or significant functional limitation despite maximal therapy, you have two options, either to continue with the standard COPD therapies or to offer the endobronchial valve treatment. My personal preference leans a little bit more towards just continuing the standard COPD therapies until we have more information. But I understand this is not only about me, this is about the patients. And it's difficult, even though we treat these patients, it's difficult to be in the patient's shoes, and and all the symptoms that they have on a daily basis. So I think it's reasonable to discuss this option with the patients. And the pros of this option is that they might see improvement in lung function, they might be able to walk more, potentially can improve their quality of life. And these are some of the number needed to treat just to make an informed decision. The cons is the high risk of pneumothorax. There is a possibility that they might die, immediately from this therapy, and that there are many uncertainties as well. If the therapy is offered, I would recommend a careful discussion about the risks and benefits with the patients. I would recommend to be very strict about following the inclusion and exclusion criteria from the trials. And then to perform in centers with adequate expertise. And I think this is the end. in the event that there are any questions for asthma or COPD, you can just ask them now, or you can come to the front.
Yeah. Thank you for two great talks. Just about macrolides and COPD. So I work in Ireland and we begrudgingly follow the NHS guidelines for this. So that would be folks that are on triple therapy and who have stopped smoking. However, I was talking to a physician last night who would often put patients with Gold Stage D on a macrolide before he puts them on an inhaled steroid, which I disagree with. What's your thoughts about if you could compare the benefits of a macrolide in COPD as regards reduction in exacerbation rate versus the benefits of inhaled corticosteroids in COPD?
Yeah, and I'm not aware of any trials that are comparing the two, but that is a very good question. I think the downside from the macrolides are the development of resistance in the patients, and then in the general population as well, and then the cardiac effects, with the prolongation of the QT, potential arrhythmias as well. So I would think that the ICS is probably more benign than the macrolides, but I'm not aware of any, randomized trials comparing these two options.
Okay.
Yeah,
Thank you.
Thank you.
Hey, Moshe. Thanks for that. Thank you.
Hey, Sanjay. I'm sorry. What? Yeah, it's fine. Just check yours here.